Welcome once again to 10 Minutes with Harry. Once again, we are talking about the interpretation of the normal pacemaker electrocardiograph. And today I would like to summarize the modes of cardiac pacing and give emphasis to ventricular pacing, single chamber ventricular pacing. There is a 4-letter pacemaker identification code that has been present for approximately 30 years. This came about when pacemakers became more complicated. They were initially just ventricular, there was some atrial, and then with the introduction of dual chamber pacing, we had to design a way of describing what the pacemaker mode was. This is a 3-letter identification code, and there is a 4th letter, R, which is to identify rate adaptive function. Every pacemaker manufactured today has a rate adaptive function. So we keep that in parenthesis. But when it is turned on, programmed on, we then add the R without the parenthesis. Let us look at the 3-letter identification code. The first letter is chamber paced. This can be atrium, ventricle, both of course, with D, and if there is no pacing, then it is O. The second letter is the chamber sensed. Again, atrium, ventricle, atrium and ventricle, or no sensing at all. Once we do have sensing then, we need to know the chamber response, and this can be none, or it can be inhibited, triggered, or dual D, where there is a response, an AV response, which is usually inhibited, but also a third function then is that A triggers the V. For example, we can see here VVI parenthesis R. This means that this is a ventricular pacing, ventricular sensing with inhibition on sensing, and the R means that there is a rate responsive function available. Let us therefore go now on to single chamber ventricular pacing and have a look at the ECG. We can see here, as we learned from previously, there is a stimulus artifact with the arrows. Then taking one complex, you can see in the red highlight that there is a QRS and a T wave. This is single chamber ventricular pacing. There are 3 forms of single chamber ventricular pacing. The first letter obviously is V, and the second letter obviously is V also with the chamber sense, but we can have no sensing as well. Whereas with the third letter, the response, we may have inhibited, we may have it triggered, and then we also may have no sensing at all. Let us therefore look at some examples of single chamber ventricular pacing. There are 3 types. VOO is ventricular asynchronous, which is valuable in MRI investigations, particularly with the patient in atrial fibrillation. There is VVI, which is by far the most common form of single chamber ventricular pacing, and VVT, ventricular triggered, which we'll discuss a little more in subsequent ECGs. Let us now have a look at a summary of those 3 types of ventricular pacing. It is unipolar pacing, and on the top row, we can see VOO, no sensing at all. There is a asynchronous pacing, meaning that there is a stimulus artifact going through the ECG at the same rate, irrespective of the underlying rhythm. The first red highlight is a sinus beat, and the second may be a sinus beat or a ventricular ectopic. Neither of these are sensed, and therefore the stimulus artifact occurs within the QRS or just beyond it and is during the refractory period, and therefore there is no pacing during those beats. The second form means that there is now sensing of any native QRS complexes. Once again, we can see what appears to be a sinus beat, and there is a sensing of this. So the sinus beat, red highlight, and then there is a cycling period, and as there is no further native QRSs, the next pace beat occurs, as shown by the red arrow. VVT is a little more difficult to understand. At a time when sensing was very unreliable, ventricular inhibited pacing could result in significant inhibition of pacing, which could have been disastrous. As a result of that, the initial sensing pacemakers were all VVT, where there is a full discharge into the sensed QRS. As a result of that, we can, as you can see on the third row highlighted, a QRS complex with a stimulus artifact buried within it. This means that if there is a spontaneous rhythm, it appears to be pacing at a faster heart rate. But this is not pacing. This is just sensed, and as a result of that, the energy is delivered into the QRS where it is ineffective. There are on both sides of this two red highlights showing what we call fusion beats. Here, the stimulus artifact occurs at the very same time that a sinus or native beat is being conducted in the heart. Let us therefore look a little more at fusion beats. Here we have a rhythm strip with a bizarre appearance, but it isn't at all. The first two complexes on the left, red highlight, are fully paced complexes, whereas on the right, in yellow highlight, they are sinus rhythm with a bundle branch block. Between them are what I call the progeny, or ventricular fusion. Imagine that the one on the left is a father QRS and one on the right is a mother QRS, and the progeny between them. And as you can see, these two beats look differently. The first on the left looks like it's parent, the father pace beat, whereas on the right, it looks like the sinus beat. And in fact, there is a P wave in front, but with a much shorter PR interval. Fusion beats occur when there is insufficient time to sense and inhibit the next pace beat. One of the ways of looking at this is to draw a line through it, as you can see, and follow the T wave. And you can see that the T wave of the first fusion beat looks similar but smaller than its parent, and whereas the one on the right it looks more like the inverted T wave, and therefore this helps us in determining how much each of those complexes contributes to the fusion beat. Let's look again at this complex. You can see that what is happening is that the fusion beat looks like the parent pace beat. This is because the pacemaker is beginning to depolarize the ventricle at the same time as the sinus beat is being transmitted through the His-Purkinje system. So just some of the area, probably around the septum, is depolarized by the sinus mechanism, and the rest is by the pacemaker. Hence, 95% is coming from the pacemaker. Whereas the second one, as you can see here, is now depolarized virtually throughout through the sinus mechanism, and only a small area around the pacemaker lead is actually depolarized by the pacemaker. Remember that this is not pacemaker malfunction, but rather the impulse has not had time to traverse the myocardium into the area around the pacemaker and therefore inhibit the pacemaker output. Let us now return to VVI pacing. And as you can see here, there are two complexes. Firstly, the pacemaker, and then we have two of these, and then at the end we have another two, and we have a cycling period. Now, the next pace beat should occur when there is a stippled arrow, but it cannot occur because there has been a spontaneous ventricular ectopic, and this then inhibits the next output. Following this, there is a sinus beat, first degree AV block, and the next sensing is occurred where we can see the blue stippled arrow. There is then a full cycling period and then the next paced QRS. Here is another example which causes a lot of confusion. Here we can see the pace beats with the red arrows. There is a ventricular ectopic present, and there is inhibition of the next output. But there are P waves present. And one must remember that we have only a single lead. We cannot sense what is going on in the atrium, and therefore this is not malfunction in that the sinus P waves play no role in the sensing of the ventricular pacemaker. Here is another example of atrial fibrillation, where quite frequent native beats, all at different rates. And to the right, we can see ventricular pacing, where the 1,000 milliseconds between the two pace beats, or 60 beats per minute. One can see then that we have a ventricular sense beat, another 1,000 milliseconds, and then the next beat that occurs is again a fusion beat, because we have a ventricular stimulus artifact followed by a QRS and T wave, but virtually all of it is due to the sinus mechanism. But again, look at the T waves, and you can see the contribution of each. Here is another VVI, which is troublesome in that there is long pauses present. This patient had the pulse generator implanted in the abdomen, and this was in the early days of pacing. And every time the patient tried to sit up from the supine position, what happened is that he would inhibit the pacemaker with abdominal myopotentials and would then fall back again. And this patient had a pacemaker which was non-programmable and required, therefore, to have it replaced with an asynchronous model. Because of this, these VVT triggered pacemakers were designed very early, and they played a very important role in the original sensing. We can see the pace beats quite clearly with the red arrows. And then we can see these other spikes, stimulus artifacts within the QRS of the spontaneous native beats. And I'll show you this to highlight these. There is a full output into these QRS complexes. Toward the end here, you can see in blue highlight, again, a fusion beat, which were very common in this type of ECG. In fact, we would almost always see it. There is another concern with ventricular pacing in that if there is heart block occurring with anterograde block, sometimes there is, however, retrograde block. No retrograde block, so that the pacemaker can now conduct backwards into the atrium and depolarize the atrium. This means that the P waves, the retrograde P waves, contract against closed AV valves, resulting in blood being pushed retrograde both into the veins of the neck as well as into the pulmonary veins. And this can be very symptomatic. And we call this the pacemaker syndrome. Of course, it is cured by upgrading the patient to a dual chamber pacemaker where there is atrial pacing or sensing prior to the ventricular pacing. There is another function I'd like to show you, and that is ventricular hysteresis. In this example, we can see VVI pacing at 50 beats per minute, 1200 milliseconds. There is ventricular pace beat, and then there is a ventricular sensed beat. But here in this example, you can see that the sensing period is longer than the V pace to V pace part. So that's 1200 milliseconds. And now, and here is another 1200 with a ventricular fusion beat again. And then the sensing zone is 1500 milliseconds. Ventricular hysteresis was a function even in the days before programmability and could cause a lot of confusion on the ECGs, particularly in this scenario where there is atrial fibrillation present. And as a result of that, we can have significant pauses. And these pauses may be similar to the pauses that the patient had before the pacemaker was implanted, and therefore is not particularly desirable in atrial fibrillation cases. So what have I learned today? There is a 4-letter pacemaker identification code. There are 3 combinations of ventricular pacing, VOO, VVT, and VVI. Fusion causes confusion, and ventricular pacing may result in retrograde conduction. Ventricular hysteresis extends the sensing window. Thank you.